So imagine yourself, you're sitting in your room and dealing with your daily work and task, and the phone rings, and the therapist on the other side is frantic. Come over here, a line is not working. And you drop everything and you just run. And you see the patient is on the, I gotta get this accustomed to. You see this error on the screen, and the patient is, therapists are excited, and they don't know what to do. What's going on? And all of a sudden, you just start thinking about all the possibilities that's going on. I'm Serpil Chaputlu-Wilson, and I'm glad to be here with you here in Texas. And I work in Rock Hill Radiation Therapy Center, which is one of the 25 locations of Levine Cancer Institute in Carolinas. It's half an hour south of Charlotte. I will be talking to you about the implementation that we succeeded in pretty much 3 weeks. My objectives today is basically how we started step by step with Align RT and going through the acceptance and the commissioning, the QA programs, and finally going through the SRS program on our 21 LINAC 21IX. And some of the special cases and challenges we went through the process. And by the way, I'm known to have a little bit of a Texas accent. If you don't understand, just stop me, and I'll get comfortable. And disclaimers, none. I'm not affiliated with Vision RT, but I'm glad to be here and grateful. First steps with Align RT, little history. We have 2 external beam machines on Rock Hill. One of them is 21IX, and it's 9 years old, and we have a 13-year-old 21EX. We are about to go to a true beam with Align RT. Hopefully it will be soon. And when I was in the main hospital, when they told me you're going down to Rock Hill and you're gonna implement Align RT in mid of June 2015. So the doctors and management were already sold into the idea of Align RT and SGRT. So that was the most important step in the process. So the cameras were already in the vault, but it didn't go through the acceptance testing. So the doctors and management, they wanted to get the program going, start using in terms of patient positioning, better accuracy, and less imaging and motion management. So the first meeting with the therapist and the department was getting the team to understand the anxiety and the involvement, and building the team and talking about it's going to create the chaos and the process is going to go through, but we will go through as a team. So I did my self-education. A lot of research papers are available, AAPM task group reports, and the early adopters and Vision RT guidance. We had 2 OSMS systems before us in the system, and Align RT was about to be working on another clinic like ours. So I did site visits, I talked to their physicists, I talked to their therapists, what they liked, what they didn't like. I gathered the information. We did not have the SGRT community back then, and I was nervous even to find out whether it was there. So, first steps with Align RT. Vision RT system has step step-by-step guidance that leads you to get your system up and going. And if you follow their steps, I believe that anybody could get the system working in their whatever the environment and system has. And any add-on system is definitely has to be checked and go through for your clinic's needs. So for the first phase 1, we went to Align RT site in Maryland. It's 3.5-day education. And as soon as we came back that weekend, it was me and one of our therapists. When we came back, my first 2 days of it was just planning who is gonna do who. Everybody is very busy. We have 2 doctors, 6 therapists, directors and director assistants, and we wanted to, I was the it, basically. I wish I had other physicists to help me with the daily work with almost 60 patients, and I organized it, I planned it, who is gonna do what. My room was full of papers and chores and homeworks. So at the end of that weekend, we sat down and with my therapist, we basically, we shared whatever we learned when it was fresh. On top of that, hey, we are gonna go through the webinars. And here's a tip that I did. I told my therapist, hey, if we don't succeed, if we don't pass this webinars, we are not gonna get approved on the system. So there is an exam at the end and they are like, everybody's studying, and the doctors and management was so into it that they gave that 15 minutes for every therapist during their work and let me be with them on the PowerPoints, ROIs, before the webinars. When the webinars started, they were so involved and engaged, and at the end, they were so happy, you were just kidding with us. So it was all white lie, but it worked. They were engaged, and they asked so many interesting questions to the trainers on the webinars. And thirdly, the now on-site visit. And do your homework. We did. Our doctors, everybody did their homeworks. And what they did is they are there for, I guess, 1 day or 1.5 days. We had all sorts of patients. We had DIBH. I made masks for whole brain patient. We created open mask. Just to try. We are not an SRS commissioned at that time, just to try to make mask making, play with the table extension, the knobs. We did a whole brain treatment with the open mask. That was good. While the trainer was there, we made the best out of it. Acceptance and commissioning. And while the system is not, we are not using the system, so I went through the acceptance. Basically, hey, it's bought up, go through the step-by-step. Hey, you bought this, it's working, and they are just selling you. Can you use it in your clinic? No, not yet. We have to do the commissioning and making sure that this add-on system is validated for your machine, for your other equipments and the systems, your CT, from your CT to your treatment planning system to your treatment, and adding on the Align RT, they all need to be validated and talking to each other properly and for all the possible clinical situations. First, I check your machine. You have to eliminate anything and everything is wrong with your machine. So I did all my TG 142, 40 mechanical checks, lasers, ODI, you name it. And the rest, I strictly followed AAPM TG 147. That task group talks about the quality assurance of non-radiographic radiotherapy localization and positioning system that is FDA approved already. It has Calypso, RPM, Varian RPM, and ExactTrack, and compares them gives you a roadmap of how you're going to do your QAs and acceptance and some of the challenges with each system, which is great task group. I know ins and out of it by now. And during that acceptance and commissioning, I used Emily Phantom, IsoCalCube, and table extension. It came with the VRT system. And here's our, when we ordered the Emily Phantom, when it came in, we are so stressful, everybody is like working hard. It created a lot of jokes, and it was good for our mood. And here is Emily, our therapist, holding the Emily. Back then, we had the Gate CT in our CT room, and with our old GE CT, and then we got the newer one, and now we use the motionless, the 4D. So what are you doing with the commissioning? You're checking your integration of the equipment, the data transfer. Basically, all your patient information is going through correctly from your treatment planning to your Align RT system. You have to check that. And then you have to check your IsoCenter, your DICOM, if they are going through the system. If you scan a prone patient, is it going as a prone? So Emily was my friend in after work hours, or IsoCalCube. I scanned it, and I did a lot of physical testings on them. For localization of displacement accuracy, you set an IsoCenter, you move from IsoCenter in like 5 centimeter, 1 centimeter, 1 millimeter, whether you actually move that much. And you prove that with your MVs and KVs for your translational shifts. And then you also, this task group also talks about how the camera systems or infrared systems that they can drift, and it's not good to use them the first 90 minutes. So you check on that. And as a security now, we don't shut down our cameras. We don't want them to cool down in the morning. We usually have a mark on it that don't turn off. And if we have to reboot the system or repower the system, we turn it off. We don't let it. So we don't get this 4 millimeter drift that they are causing when it cools down. Or you're not supposed to do QA during that time too. And dynamic localization accuracy and spatial and temporal. In Align RT, you can set your timing, how long it goes off. You have to check that in terms of, is it 1 second? Is 1 second, actually, would it stop the beat? And on top of that, you need to set your QA programs. Yes, you check your Align RT. It's working for your clinical. You commissioned it. It's working for your clinical situations. But how are you going to test it day to day, month to month, yearly? So again, daily, the therapist does the warm-up using the plate. And then later on, I integrated Align RT into their imaging QA. We use a modest imaging QA box. And I scan that, and they can do their imaging. While they are doing imaging, they can pull that as a patient, and then they can check. Because when we do OBI testing, and Align RT is a complete system, it's coming, warming up I don't think is just enough. We need to see whether it's actually working for that day for some reason before you start treating your patients. For monthly QA, there is a calibration plate calibration, the plate calibration monthly QA, and also there is an IsoCal calibration. They both do different things, and the IsoCalCube basically fine-tunes your calibration that you do with your monthly QA. And that needs to be done after your every monthly QA check. There's a recently published paper just in this December that UCSD group, Adam Paxton, I think he's in Utah now, they did a study whether you can rely on only the plate calibration and how much shift is going to propagate in terms of errors. And they definitely say that IsoCal cube calibration needs to be done. And the annual QA is basically end-to-end tasks, meaning from the CT scanning and going through the whole process, how it transfers the treatment planning system, and then your counters going and doing everything that you do in monthly and translational checks as well. So this is a screen that daily imaging, the Modus Cube there, they set that up, and you have an offset laser. From that position, your Align RT is giving your shifts to the center. You can see the deltas are all in red. And then you do your KVs, apply your shift, the shift goes to the table, and the cube, your deltas are all in green. And it is 2 millimeter, 2 degree. Okay, while you're setting all the QA program, you need to also set your system. And how are you setting your system? Everybody has their own clinic systems that they want to do. Who will be using your system? Your users, their rights, their tolerances. And some people uses a generic user. Everybody in our system, everybody has their own logins. So when we have reports, we know who did and who was treating. And the rights, who is going to have how much rights. Some people start with less rights to the therapist, and then once they get accustomed to the system, then they increase the rights. And the tolerances, what kind of a system you're going to have in centimeters, in millimeters, or whether you're going to have variant system, IEC. Those are all the things you can set up. Also, what you're treating and how much margins you want, your tolerances. You can all set in the background as an admin. And record and report, that's one of our challenges was in here. We wanted to print the reports into our EMR, but CHS system, because of patient safety and HIPAA rules, they don't allow a third-party vendor system in our computer. We find a trick to print the reports without any flash drive or anything into our system, and now our therapists are very comfortable and easy. And our doctors, the Vision RT report was 2 pages. They are like, oh, we are busy. We don't want to go through 2 pages and sign it off. And how can we compile this? We compiled it to 1 page. Now it's just 1 page, and they just look at it and they sign it. Continuing education and competencies, that was another thing that we needed to set. We can't just have any therapist coming to the system. They need to be able to know really well. So who is going to train them? That was another thing that we had to decide. How long they need to be trained. I have therapists and advanced therapists. And advanced therapists are, basically, I teach them how to do a monthly QA. Because I am not there. I'm actually a morning person. I'm there most of the mornings. But on other sides, I teach them how to do a monthly QA. Plate raise, raise plate or regular, they know from end to end. If they can do that and I approve it 3 times, they are good to go. And their eyes are better than mine. They do a better job than I do. And then they are advanced therapists. Because I don't want them in the mornings, because if you mess up the daily QA 3 times, it wipes out your monthly QA. So I don't want them to just stop there and wait for therapists or get frantic. What are we going to do? How are we going to take Align RT from ADI? So I tell them, don't worry, just do your monthly QA, and when I come, let me know, so I can do lunchtime my IsoCal cube. So far, in 2.5, since mid-15, we had not had one time any of my advanced therapists did, it has not broken. Because they know as soon as they fail the daily QA one time, they go back and check their setup. There's definitely something wrong with the system. And I tell them, if anytime that you are not sure, just take the ADI off, don't use the system. So, and one of my tricks to them, I take the ADI off in the morning. I'm sitting in the room, I wait. That's another, they have to pass that test to become an advanced therapist. They're like, oh, what's going on, you know? And then they check everything and they put it on and they come and kill me. Here are my first advanced therapists, and I crown them with the little brownie pops. Setting procedures. These are all going during this 3 weeks. Of course, I'm working nights and days and weekends. And it's a really, really hard pressure. It's like the one that it turns coal into a diamond, that kind of a pressure. And plus, this is your first big project. You know, you want to be succeeding. Setting procedures. OK, we created one general procedure from each department. When the patient comes into the room, what happens? If it's going to be a line art, who is deciding? The doctor at the consult does the patient education. What kind of an education he's going to give? Because we have how much you tell the patient. This is really important for us because in one of our machines, we don't have a line RT and the other one has. So we need to know how much information we want to give because one machine goes down and we take the patient to the other machine and they say, oh, is my cardiac, you know, how much information you need to give them? Do you really want to give them that information? So they feel like they are not being treated right. So that's the one thing that the doctors, you know, is really good at. And the second thing, I really wanted to add a patient education slot there for either dosimetrist, therapist, somebody, but we are always like tight staffed, so we don't get that chance. So most of our education happens in the sim. The more time you take in the sim, this is with my experience, it's better at the treatment. The way that you train them how to take a breathing, you work with them, and you time them is really important, how it sets up in the treatment. Because if you just do once or twice, and then they are taking a really, you know, high deep breath, and then you go out there, they are taking their normal breath, and they have to do it like 3 fields and 2 KVs in a Linac day. Like at least 10 times you take deep breath. They can't, it's not real. So you have to spend time in sim when you are setting up a DIBH patient. And then the planning. We have an Align RT system, so we have extra box in dosimetry. In a lot of OSMS systems, they have only one box, so the therapist pulls in the patient, creates the ROI. In our system, I get the dosimetrists exported, because I want them to involve in the whole thing. They know the plan better than the therapist does. They know whether the plan has the bolus, the IBH, because you have to generate fields for each of them. So our dosimetrist does it because it's convenient. I get her to do it. At the same time, I go back, I do my physics checks, if the isocenter is correct, if the SSDs are correct. If it's correct, I come even for free breathing. We had this happen because it was pulled in 2 DICOMs, and they were both DIBH DICOMs, not the free breathing. We have the free breathing DICOM to set the patient up in the treatment, and then they go on to the DIBH DICOM, and they start treating and filming. And I had to set up the initial and weekly physics checks and how we are going to do it. The general IGRT, for a lot of IGRTs, we use Align RT. And you're filming it, then you're using Align RT for the motion management and localization, if the patient moved or not. And those are easy checks. But when it is DIBH, it takes a little bit of my time. I have a couple of ideas to VRT people for future improvements. For those, I have to kind of check on my therapist whether they are following the procedure. What we do in the LINAC, we LINAC the patient. We take the images the first day. If they are really happy, they take a reference image. That reference image the next day with the tangents is approved again. They go to that reference image. And if they are happy with that, their worth is set, their lat is set, they go through their week using that reference image. And if they have any time, any question, I tell them, go check your setup first, and then take a MV image if you're not sure. And if you're not sure, you can take even KVs at that time. But system works. I believe in the system. Oops, how do I go back? Hold on. And another thing is, how are we? Because when we started getting the reimbursement and stuff. So we had to also work on the reimbursement, who is charging what we are charging. And the most important thing is the communication in the department, how we are going to let other person know. We don't use the care path in Varian right now. We use our doctor's prefers task paths. So our task paths is our email system, is our communication. And what we do, what we treat, as soon as we started doing everything. We didn't have only the IBH. We had all kind of partial brass, full brass, all brass, right, left. One of our doctors from back then even, he was very fond of the IBH because he wanted to control the liver dose and lung dose. And when I was coming here, he gave me this paper that it just published in this session about how the ipsilateral lung dose can be controlled with the DIBH on the right breast. And we don't do any prom breast, pelvis, palatal and electrons, head and neck. We don't do them because limited scheduling. We cannot have everybody on one machine. We have to have some for 21EX. But TrueBeam is about to come. So electrons, we tried electrons, and I think electrons can be done. And I think you just need to generate your ROI on the other side, not where the cone is, because the patient breathes. So you don't have to do a isocentric ROI. You can do a concentric ROI or non-isocentric. And it can be done. Is it worth it? Yes. For patient motion, maybe, just for the safety issue. But is it? I have questions on that. SRS program. In 3 months, starting into our program, we did with the SRS commissioning. And then we did the machine, okay, we had to do the machine alignment. We upgraded our IX with the IsoCal upgrade. That does correct your imaging system, basically. And then the SRS program, we commissioned our machine following all the tests that we need to do, TG101, all the task groups. On top of that, I had to do the Align RT part of it. We did all these tests again using the head adjusters. We had to set all the programs again. Here we go. Going back to our original question. I'm sure some of you had, and this message is about no contours available for gated CT, for gated tracking. So what do you think it was? This was, I looked at the guy anatomy. He was a very big person, and it was, I think, blocking one of the cameras. And I generated a 9 isocentric ROI. And we were back in the But we were still missing some information over here, black. That was like bugging me in my back of my head. So I went back in. We had another patient. We had the delta fluctuating, jumpy, jittery, and my therapist is again asking what's going on here. Initially, okay, sorry. The skin color was fair. We changed that, and then we changed the ROIs to a larger ROI, and that helped. And you see up there, it's still some part of the chest is black. So that was due to, I went in and checked his skin. He had hair. I put a tissue there, not tissue actually, it was a washcloth. I put a washcloth, came out, and we were grabbing that. And from then on, for that patient, it was an esophagus patient. We took him off of the Align because the doctor didn't feel comfortable asking him remove the hair or anything. And we didn't want to treat it with the washcloth there. So, but later on, we added onto our procedures to check for bodily hair if we are treating in the area. And these are our SPRT cases and how we have in their chest the ROIs generated, and usually we are online. These are the reports. And we added that to our SRS mask-making procedure, and we get them remove their mustache and beard. And for this specifically, this patient, he had, I wasn't there for that treatment, but he came in, shaved his head too. It was tough for the treatment because of the mask was. And there insufficient surface overlap error can happen. For this patient, we had that issue, and the patient's skin was so shiny, and again, she had a big belly. We have a magic black towel in the room. We use sometimes that it concentrates on wherever our ROI is. And the same way, we have a colostomy bag in the treatment area, and just where the isocenter is, and she was scanned this way, and because of, it's like acts like a bolus, and it doesn't sometimes grab it, we ask for a permission to use a washcloth, and here we go. And conclusion. Align RT is a very robust and reliable product, and it's very easy to implement it to any clinic, any system. And if you follow step-by-step the directions and AAPM reports. This is my opinion. I kind of searched when we started using audio systems and video systems for patient surveillance. And I believe every machine needs Align RT kind of a system that we watch patient closer to where we are treating, whether they move or not. And especially like after cone beam CT that we are waiting for the doctor to come in, and you have to see that is actually patient is not moving. What you did like about 3 minutes ago is still the same. Here is my team. I couldn't do this without their help. Dr. Thacker and Dr. McCammon and our group are physicists and dosimetrists. Tumor terminators, we call each other. And my site visits to Megan Bright from Northeast and Kara Sullivan helped me. And I also, before the SRS implement, I went to the UCSD for site visits, and they were very helpful through the implementation. Any questions?
I noticed that you use the black towel to block out the areas that you're not treating, because sometimes it carries over to the contralateral breast. Would it make sense just to normally put a black towel on the other side?
We haven't tried that because I try not to create any shadows because that's really important. For one of our patients, I just wanted to go and put a tissue there. For some reason, I can't remember, that even that tissue was creating a shadow. And I just took it away. You just have to be careful that it's not creating any kind of shadow.
What does the
Shadow
shadow
left.
have to do with the VRT? I'm not quite understanding that.
Shadow creates a black, the speckles doesn't, it doesn't grab speckles. So shadows are really, that's what the hair is. Its hair is, because of the hair, there's a shadow there. And it's not getting the speckles all to the all the way to the surface and grabbing the image, the surface. That's why.
Wouldn't you want not to grab the other side?
I mean, if it is, we do this like SPRT, I do the black towel. Sometimes we use a compression belt. It goes and grabs that. We put it softly on top of it, but just be careful. You can try, but just make sure that it is not coming to where you want to, your ROI is, and not creating any shadow. That's all I'm saying. Because we sometimes, for the patient discretion, they try to cover the other side. Even that creates problems. So I try to keep it open as much as possible.
Because we do cover the other side, normally with their gown, whatever
Yes.
color that may be. So you're recommending no cover at all?
This is, yeah, what I believe, that you shouldn't have any much of a cover in the area.
Thank you.
Okay, thank you.